Hi, this is Dr. Sam Asasa, the president of the American Association of Aesthetic Medicine and Surgery and the founder of Beverly Hills Aesthetics. It is with great pleasure that I'm here today to introduce you to our online aesthetic training courses. We're extremely pleased to have the International Academy of Aesthetics, the IAA, as our partner. They relentlessly worked hard to provide us with an outstanding platform and incredible support, which enable us to deliver the state-of-art training program that can be reached by medical professionals like yourself across the globe. Today we're doing a facial analysis on this model, and I would be doing complete facial analysis. A systemic approach is recommended when assessing aesthetic patients. But this approach must be individualized according to the patient needs and the injector assessment. However, some important aspects should be considered, including the following: the facial shape, the facial proportions, symmetry, and facial units. First, we have to take the history to explore the reason why the patient is seeking our expertise.
My concerns are this expression of being upset and this sadness. I don't like this, and it doesn't represent what really I am. And I would like to improve these lines, and probably here in the side of the eyes, and make it feel younger. And probably this on the cheeks.
What's for the
need
cheeks?
A little. To be a little more
Fuller.
fuller, yes.
Okay. There are four things that we want to cover today. We need to assess the facial shape, the facial proportions, symmetry, and the facial units. The first aspect of the facial analysis is to analyze the facial shape. This is based on Torino and Flowers studies. It is an important information regarding how close or how far are we from the ideal oval shape. The ideal aesthetic facial shape is oval, which is considered as being the most attractive shape in female. We need to see the proportions of the upper, the middle, and lower third zone of the face. Normally, these three aesthetic zones are equal in dimensions and height. Also, we would like to assess the patient's face while their head is tilted down. This exaggerates all the shadowing where the volume loss is present, as you see in the suborbital area. Also, this position helps us assessing the amount of skin laxity, ptosis, and droopiness of the soft tissue. By tilting the head down while the patient is looking up, you can also see how exaggerated the presence or appearance of the fat herniation seen in the suborbital area. Volume loss in the tear trough, volume loss of the mid-cheek and lateral cheek areas, and of course you can see the nasolabial fold being thickened because of gravity and secondary to the volume loss of cheeks area. We can also see the jowl being exaggerated by this position, perioral defects or deficiencies that are magnified by this position. When assessing facial shape, we assess the frontal view and would like to assess the profile or lateral view. There are different facial type of patient profile. In Maria's case, her face profile is a straight line. You can see when you draw a line from the glabella down to the chin area, her face is aligned along the vertical line. There are two other different kinds of facial features or shapes. One is convex and the other is concave. These facial shapes, the convex and the concave, are more difficult to improve aesthetically, and they are challenging clinically from the aesthetic point of view. Normally, 99% of people we see in our offices, including ourselves, have asymmetry. As a general rule, being an aesthetic practitioner, you should always accept some asymmetry, as long as it is not very obvious. Our aim is always to avoid creating asymmetry after any aesthetic correction. So now we have already finished our initial facial aesthetic assessment, which are the facial shape, facial proportions, and asymmetry. Now we need to assess the facial units. Here we have to divide the patient face into 3 aesthetic zones. The upper third of the face, starting from the hairline to the glabellar line. The middle third, starting from the glabellar line to the base of the nose. And the lower third of the face, which starts from the base of the nose to the chin area. These horizontal thirds should be equal in length, 1/3, 1/3, 1/3. Also, the lower third of the face is subdivided into 3 segments. The distance between the base of the nose and the upper lip, and the upper lip to the chin, with a ratio equaling 1/3 to 2/3, or 1 to 1.6185, which is the phi number which we'll be discussing in details in our courses. It is very important when we assess the aesthetic zones is to evaluate the patient while they're resting and while they're animating to see if there are any expressive lines present, which we usually call wrinkles in motion, and also to assess the alteration of volume of the facial subunits. There are 2 concepts that we need to implement when we analyze the patient's face aesthetically. First of all, most of the people who come to you, they don't come to you and say, I have a deflation of my cheeks or flattened cheeks. Instead, they're bothered by the shadows that are created by the volume loss, which gives their face look a tired look instead of fresh, bright look. For example, if you look under Maria's eyes, please look up Maria, you should see the shadows that are formed now and caused by a loss of volume. Right here, with increasing volume, the suborbital fat and pseudoherniation. Also because of the loss of the volume of the cheek and mid-cheeks area. Alright? The second concept is actually the perception of emotions that are projected from the person's face. When people get to their mid-50s and 60s, and of course there are differences in Asian symptoms presentation that are related to differences in ethnicity, genetics, and general health, their faces tend to turn negative signals, also called the negative vectors, or signals of sadness. So let's address those factors present on Maria's face. Starting cephalad and going downward, we see the lateral eyebrow tail is pointing downward. That is the first negative vector. Then we observe that the lateral canthus is curved down, which is the second negative vector. So far, we have the lateral canthus negative vectors and lateral eyebrow negative vector. Let's look up. Here's the negative vector of tear trough and the mid-cheek volume loss. And as we go down, we could see the nasolabial fold groove. That's the fourth negative vector. Then as we go down and look at the marionette lines, the mouth corner, and the oral commissure, which are the fifth negative vector. This is followed by the buccal fat, which is the sixth vector, and the seventh negative vector, which is the jowl. So let's review the negative vectors. There are 1, 2, 3, 4, 5, 6, 7. And with a loss of definition of the mandible angle, this will make the eighth negative vector. So to qualify the Asian changes in Maria's face, we're going to say to start with that Maria has heavy set of eyelids which are tilted laterally and downward, frown lines caused by her strong frown muscles, low expressive horizontal lines along the frontalis. Then she has fat herniation in the suborbital area, the tear trough, and a medial cheek volume loss, decreased prominence of the zygo or cheekbone arch protrusion, and ptosis of the buccal and jowl fat, marionette lines with downwards oral commissure, and thickening of the nasolabial fold. Now that we discussed the qualification of the problems of Maria's face, it's time to do the quantification of the existing problems. The eyebrows here are slightly ptotic, I would say 2+. The frown lines are significantly improminent, so they are 4+. Forehead lines are very mild, about 1 to 2+. The fat herniation under the eyes is about 3+. Tear trough and mid-cheek volume loss is about 2 to 3+, and definitely the nasolabial fold full thickness is about 4+. The marionette lines and oral commissure is about 4+, and finally the jowl fat is about 3 to 4+. Now you want to put a plan of action. This is very important and crucial step for the patient to be involved in this plan of action. You have to make sure that what you are presenting as a goal for correction plan matches the patient's needs and expectations. Here you have to spend the time explaining why would you do things and how you're going to do them. Maria has concerns about her frown muscle, so neurotoxins in this area will be extremely beneficial, not only to soften those lines, but also to give her medial eyebrow lifting by injecting the corrugator muscles and procerus muscle. The second area to be addressed is the eyebrows. I would give her a little eyebrow lifting laterally, and there are two choices for that. One is using the neurotoxin to weaken the depressor muscle orbicularis oculi right at the temporal fusion line, or injecting dermal fillers above the brow, which would give her a volume lifting and should eliminate the eyebrow negative vector from the formula. For the lateral canthus, the best way to eliminate the negative vector is to inject fillers in the temporal region. Also, injecting the zygo area will eliminate the two negative vectors, the tear trough and the mid-cheek volume loss. So we have already addressed the first and second negative vectors. Now we could address the third and fourth. As we said, in order for us to improve those vectors, we could do the following. We said that we could enhance the zygo prominence right here, which is basically if you draw a vertical line extending from the lateral eyebrow, where this line intersects with another line that is drawn from the alar area to the tragus area, right here at the bone, and you could feel it. That is where the prominence is. As you see, because the volume loss in the mid-cheek and some volume loss there, right in the tear trough, in order for us to correct it, we need to first enhance the mid-cheek area, which raises or causes lifting of the cheeks to almost the lower edge of the lower eyelid, and also it has indirect effect by correcting this tear trough. Also, please note, if we fail the zygo arch and the zygo prominence, you're going to see a lifting in this direction, which will eliminate the negative vectors of the tear trough, the mid-cheek, and the nasolabial fold. Now we're going to address the oral commissure or the marionette line. This by itself is called marionette line, but it should be called the marionette region. Here is a significant volume loss of the soft tissue, mainly the superficial fat, including also the bone reabsorption, which causes the structure of around the mouth to be really collapsing, which causes the structure around the mouth to be pulled inward or sucked inward. To complicate matter, as we age, there's an increase or hyperactivity of the depressor anguli muscle, which pulls the mouth corner downward, and hyperactivity of the mentalis muscle, which creates or deepens the chin crease, and here, causing less definition and or projection of the chin. And finally, the platysmal muscle effect as we age, also they become hyperactive, causing some downward pulling of the lower third of the face and the jowl area. As you see here, the lateral platysmal muscle pulls down laterally the lower third of the face, including the jowl area. In order for us to eliminate or correct the negative vector of the oral commissure, we need to volume replete the area by using dermal fillers. And to start with, we need to identify where it is the maximum volume loss is. As you see, if you pinch the area, you know that this is where the maximum loss volume is. So this is where we're going to start. We always start injecting the fillers from the top, going down in our correction, not the reverse. As you see in this video, I'm trying to manipulate tissue to simulate the effect of the fillers. So in order for us to correct and to create this effect, we should put the fillers right here. At the end, once we do the filler, this oral commissure or the marionette lines will dissipate. In the perioral region, I believe dermal fillers play a significant role in rejuvenating this area. Starting with the oral commissure in the mouth corner, by just doing a little scaffolding with the fillers, we can bring this negative vectors up to a horizontal alignment by simply injecting the dermal fillers. Also, you see those creases that are caused by the mentalis and expressive muscles around the mouth corner. These lines or wrinkles could be easily corrected by expanding the tissue by simply injecting dermal fillers subdermally right there. So with a dermal filler injection right there, we could eliminate the marionette lines, soften these wrinkles, or even out the peak, which is the jowl, with the valley, which is the marionette depression, as you see in this demo, to become situated in one plane. This is also called contouring of the lower face with the fillers. As you see here, look at Maria's jawline. Overall, it's a very well defined for someone at her age group. If she has a little jowling in this area in fullness, her jaw will be actually a 25 or 30-year-old jaw definition. So let's mark the areas that we need to inject to correct the volume loss. Okay? As I mentioned earlier, we need to fill the medial cheeks to bring the cheeks up from the position right here to that position. And if you look up, now by just filling this area with the patient's soft tissue, we brought the cheeks up to here, causing shortening of the stretch or distance between the cheek and the lower lid area, and almost eliminating the tear trough defect. So by injecting this area, we indirectly corrected the tear trough. To correct the marionette region, we need to squeeze the marionette soft tissue to see where the maximum volume loss is. As you see, it's right here. And it's less as you go down. So most of the volume correction should be positioned right in the upper part, and as you go down to fill the area, you fill it with less volume. If you look at the jowl, this represents a peak, and the marionette region represents a valley. So our goal is to lift the tissue of the marionette region from here to make it situated at the same plane, almost at the same plane as the jowl, creating nice smooth contour. And let me try to simulate the results with my fingers. Our goal is to eliminate the shadow and bring the valley close to the peak, which where the buccal fat and the jowl area are located. So by creating volume in this area, we are going to lift this tissue up very close as far as the plane to the adjacent buccal and jowl area. And that also needs to be corrected by actually injecting dermal filler at the mouth corner, starting from this angle down to the vermilion border right here and in this direction to create some support of the lateral mouth corner and oral commissure. It is so crucial to have a thorough knowledge of the anatomy of the face to know where we should inject and to avoid the area that we call danger zones. If we pinch the skin right here, where you see the skin groove, this is where the supratrochlear artery passes. By pinching the second groove right here, this is where the supraorbital artery runs. These two arteries are situated very deep at this level, but as they flow upward, the 2 centimeter above the eyebrow and supraorbital rim and higher, they become superficial. And that is why it's very important to know that when we inject in the forehead area, to be injecting in the deep layers right at the supraperiosteal and the subgaleal planes to avoid injuring those arteries. So as you see, Maria has a little hollowness right here. By adding volume to this area, we will be able to create a volume lifting like this. Okay? And if we inject right here, we are in a safe zone. Now, if we were to create lifting by injecting dermal fillers in the temporal fossa, we need to identify the temporal fossa borders. I would first feel for the temporal fusion line, which is right here. That would be the superior border of the temporal fossa. The orbital border, right here, and the inferior border, which is just above the zygoarch. Now laterally, you have a superficial artery that runs superficially close to the hairlines called the superficial temporal artery that gives two branches right here, the frontal and the parietal branch. Here is the posterior temporal artery that is very deep. In the anterior temporal artery right around the bony area. So, the posterior temporal artery is very deep, and the anterior artery is more superficial along the bone. So what makes sense is if we were to do an injection, is to inject at the superior medial part of the temporal fossa, right there. If we create a volume right here, you're going to have a lateral lifting. Now, if we did a volume increase in the frontal area right here, that would give us an upward lifting in here. So if we get to create a lifting in the frontal and the temporal area, that will give us a beautiful lateral lifting and a superior lifting of the eyebrow, which yields a very rejuvenating effect. If we were to work around the zygoarch and below it, we need to know where the transverse facial artery runs. It runs this way, just about 2 centimeters below the inferior border of the zygoarch. So the facial artery starts from the inferior part of the mandibular border and goes up in a twisted run or distribution, giving branches to the inferior labialis artery and the superior labialis artery, and it goes up and runs lateral and along the canine fossa, then along the lateral wall of the nose, branching out into the angular artery. So it is very important when we inject the nasolabial fold groove for correction is to inject the dermal fillers with a needle tip pointing away from the angular artery and towards the bony structure to avoid injuring the angular artery. Let me conclude my video by thanking you all for watching this training course and hope that my presentation simplified your understanding on how to assess and treat your patient and help preparing you to embark on an exciting journey as an aesthetic practitioner. I wish you all a very successful training course and looking forward to meeting you soon.